Hello and welcome today to talk about the psychobiology of pain, presented by Dr. Bruce Robinson. My name's Kath Berry, and behind the scenes we have my co-host Luke Rickards. We all know that chronic pain affects so many people in our population. The World Health Organization actually estimates that up to 37% of people in developed countries and 41% of people in developing countries suffer from some form of chronic pain. What this means is over a third of the world's population are experiencing some form of pain. What's consistent is that there are two clear messages from these population surveys about pain in both developed and developing countries. One is that musculoskeletal pain, that's most notably back pain and joint pain, is a dominant single type of chronic pain. And secondly, most people with some form of chronic pain actually experience pain in multiple sites. This graph here shows us the types of areas that people are experiencing pain. And of course, as acupuncturists, these are the types of things that we see in our clinical practice every day. What's interesting to note on this slide, of course, is where back pain rates as one of the highest in terms of its limiting people's activity, as well as most highly sought after for GP consultation, followed by hip and knee pain and shoulder pain. As we all know, acupuncture is a popular treatment for pain relief. Pain or musculoskeletal complaints accounts for 7 out of 10 conditions for which individuals use acupuncture, according to the 2007 National Health Interview Survey. So this explains why acupuncture is such a common and popular treatment for pain. So it's with great pleasure that I introduce to you Dr. Bruce Robinson. Dr. Robinson lives in Fort Lauderdale, USA. He's a professor of medicine at the University of Science and Technology Medical College in nearby Miami, and is also the professor at Atlantic College of Oriental Medicine in Fort Lauderdale. Dr. Robinson was the president of the AIMC Berkeley, an acupuncture college in the San Francisco Bay Area from 2007 to 2009. He is the author of 2 textbooks on the topic of integrating Western medicine and Oriental medicine: Biomedicine, a textbook for practitioners of acupuncture and Oriental medicine by Blue Poppy Press, which you can see there in the right-hand corner of your screen, and Western Physical Exam Skills for practitioners of Asian medicine, also up there on the right-hand side. A board-certified surgeon, he practiced medicine and surgery for over 30 years, treating over 80,000 patients. It's with great pleasure I introduce to you today Dr. Bruce Robinson.
Well, hello, everybody. This is Dr. Bruce Robinson, and I'm going to be talking today about the psychobiology of pain, a very complex subject indeed, and one of the most important problems of human existence, and one that you treat very well as acupuncturists. However, there are so many dimensions to pain that we will have much to talk about in this next hour or two, almost 2 hours, where we talk about this presentation. So I've listed the topics that we'll be discussing today. Why do we have to experience pain at all? The strange, elusive nature of pain, the 3 components that make up the experience of a painful stimulus, the neurophysiology and the neurochemistry of pain sensation. We'll go into some of the details about that. And the theories of pain perception, the main ones being the gate theory and the sensory decision theory. We'll talk a little bit more about the psychology of pain, which is, of course, weaving throughout the whole presentation today. Acute versus chronic pain. We'll talk about pain and personality, how pain tends to affect personality and which change comes first. We'll talk about the role of pain in human evolution. Human evolution has evolved the way it is, and it's curious how that happened. We'll talk about the clinical aspects and some important pain syndromes, such as low back pain, for example, and headaches. The attempts to measure pain, physiologic parameters, and pain scales. The treatment of pain, we'll talk a little bit about that, and we'll talk about psychological approaches to dealing with pain. So here we go. Are you ready? So Donald Meichenbaum was a Canadian psychologist, voted one of the 10 most influential psychotherapists in the 20th century. Those of you who have a psychology background may well have heard of him. He wrote books about pain and stress. And so his final bottom line statement I've quoted here: pain is the greatest and most universal form of stress. So a good question would be, why do we have to endure something so unpleasant and distressing as pain? And the answer is very straightforward. Pain is a warning of injury or disease. It's needed for healthy body functioning and protection. But let's have a closer look at this. And as we do, we may feel ourselves a little bit surprised as to how critically important pain is. Because what happens to people who do not experience pain is not good. For example, those who have neurologic diseases where they don't feel pain traumatize their joints without realizing they've done so. So we have a term for these traumatized joints. We call them Charcot joints, named after the French neurologist in the 1800s who attached his name to so many diseases and who did the original work on pain sensation. We also see deep bed sores in paraplegics who don't have pain. I'm a general surgeon and I've been dealing with these all my life. I will show you one or two heartbreaking pictures that I hope you can endure seeing because they're very unpleasant. But that's the reality of life and what happens when people don't have pain. Curiously, there's a condition people are born without the ability to sense pain. And they are soon disabled by injuries and illnesses and they die young. So here's a dramatic picture of Charcot joints in a paraplegic patient. Look at the x-ray of those knees. The joints are almost completely gone. And there's a vast amount of inflammatory scar tissue and calcium deposition as these knees have been repeatedly banged over the years by this person who feels no pain. I'm going to show you a unpleasant picture of a person's ankle and foot. This is a Charcot ankle joint. This person had to have one toe removed and has had multiple other operations. It hardly looks like a foot anymore. Unfortunate and sad pictures of bed sores in paraplegic patients. I dealt with these every day in my surgical practice. And the next picture, the one I warned you about, it's very unpleasant, but it shows the bed sore going right down to the bone, to the ischium, the pelvic bone in a paraplegic patient. Believe it or not, this kind of an ulcer can heal. And I spent a lot of my time years ago when I was in my active practice cleaning out wounds like this, packing them, debriding them, and encouraging the granulation tissue to develop and the skin to close while taking meticulous care of this somewhat emaciated patient, as you can see. Congenital absence of pain sensation, I mentioned, it's uncommon, but it definitely does occur. These people tend to grow up experiencing dental abscesses, infected joints, frequent bed sores. They don't suffer pain, but they suffer the complications of those infections and the injuries, and they often die in their 20s. Some have even died from ruptured appendix that they didn't know about until it was too late. So we were forced to conclude. Acute pain is necessary for our health and to ensure our continued survival. Chronic pain, however, is another matter. Do we need chronic pain at all? It's very difficult to answer that. I personally tend to think that we do not need chronic pain and that it is unnecessary and tragic and unfortunate. However, whenever I make a blank statement like that in a large class, I always have somebody who raises his or her hand and says, yes, we do need chronic pain, and tells the story of somebody that they're associated with where the chronic pain is helpful. But I doubt that that's very often the case. Recurrent acute pain, yes, but chronic pain, no. So the nature of pain is very elusive. One of the more interesting people to read about this was Howard Beecher. He was a military surgeon during the 1940s and World War II, and he contrasted his war experiences with his civilian practice later on, running into the 1950s. He noted during the war that soldiers who were badly wounded kept fighting as long as possible. They often reported later that they had felt little or no pain at the time. So here we have a classic example. Probably nothing is more traumatic or more horrifying than battle. And yet the curious thing is that during a battle, some of the most noble characteristics of the human spirit emerge. Look at this medic carrying this injured buddy over his shoulder and the other paramedics or medics trying to help out. I'm sure bullets are flying all over the place during this, while this was being filmed. These are the kind of people that get medals for their valor. And this man who is carrying the wounded soldier may have injuries himself. So we have a civilian situation later on that I'm so experienced with and sadly familiar with as a general surgeon. I worked in the emergency room for over 30 years. Here's a head-on crash at 110 kilometers per hour, and there are people inside who have been killed and others who are seriously injured. And I had all these people would sometimes be brought to the emergency room, those who were alive and those who were dead, for me to pronounce them dead and to take care of those who were alive. And they had terrible pain if they were conscious. Other examples of suspension of pain I'm sure you're familiar with: athletes in sporting events, marathon runners, football players. Often they can sprain an ankle or injure some part of their body, and they can keep going without feeling much pain until later. So we have opening moments of a marathon. Everybody's feeling pretty good here, a little nervous perhaps, but they're all in good physical condition. And we have a marvelous picture of perhaps the most famous marathon runner of all time, and female marathon runner was Joan Benoit. Her record for the women's marathon set in the 1980s still stands today. She often ran with sore ankles and knees, yet she finished her marathons. Attacks by wild animals are another example. You perhaps have heard that victims who have miraculously been saved have often reported feeling a strange tranquility in the face of impending death. When they knew they were going to be killed, they suddenly became limp and pain-free and tranquil. Many cases of this have happened where lions and tigers or bears have attacked human beings and they've been shot off by a fellow hunter and saving the life of the victim, and the victim then gives this report afterward. Here's a dramatic picture of an elephant attack in Kerala, India. You may possibly have heard about this. Elephant went berserk, killed one man, and severely injured the man in the picture. All the other people around are panic-stricken, but the man who was injured is curiously limp and passive. So the other side of this coin is very dramatic indeed, and it's one that you deal with in your practice. Not only do people experience pain, but their pain gets magnified. Those who are shut in, particularly in nursing homes or their own homes where they can't get out, the pain seems to become more intense than it really might otherwise have been. Hypochondriacs are another example. They feel pain so intensely, and so they're alert and sensitive to pain. I mentioned Arab versus Scandinavian patients for a good reason, because in my practice, I would practice in Saudi Arabia for 2.5 years, and there people experience a lot of pain and they complain about it, and everyone supports them. So when somebody is sick in Saudi Arabia, the whole village comes to the hospital and moans and mourns with them. So when I would take the stitches out after varicose vein surgery in my Arab patients, they would cry and moan, "Oh, oh, oh." Then I went back to my own practice in the United States, and particularly when I was in northern Michigan for several years. I took care of Scandinavian patients, and they were very stoical. They never said a word when I would take their stitches out, and it didn't seem to me that they were enduring as much pain. But at any rate, they were culturally programmed to not react to it. Phantom limb pain is very curious indeed. So somebody who has had a leg removed or amputated still has severe pain in the leg that's no longer there, or maddening itching of the foot that's no longer there. That must be very unpleasant indeed. Causalgia also has other names: reflex sympathetic dystrophy or complex regional pain syndrome. Causes a very curious severe intensification of pain in a hand or a foot that was previously injured. The classic is the hand that gets caught in a car door when the door is slammed, and then later on they develop this causalgia. There's a lot of sympathetic nervous system involvement. These people get purple discoloration, they get swelling, they get hyperhidrosis or sweating on the involved extremity. And so I've taken care of many of these people as a vascular surgeon, because I've done sympathectomies, lumbar sympathectomies, or for their legs, or cervical sympathectomies for the upper extremities in patients with causalgia. Fibromyalgia patients are widespread throughout the world now, probably the most common pain syndrome there is. And studies have now finally identified something that's positively studyable in fibromyalgia, because most laboratory studies are normal. They have increased levels of substance P in the cerebral spinal fluid, maybe with a greater sensitivity of ELISA tests will be able to detect increased levels of substance P in the bloodstream and in the tissues as well. So that we have to have a conclusion here from all this discussion so far. Pain has a powerful physical basis, but it also has an important perceptive basis and a strong psychological or reactive basis. But we're going to talk a lot about that today. So what are the three aspects of the experience of pain? They are physiologic, they are affective, and they are evaluative. We'll talk about these in turn. So the physiologic sensory aspects, there is the stimulation of the nociceptors in the tissues of the body that experience the sensation of pain. So the full pain sensation, when we have it, it is determined by the extent of the injury. If you hit your finger with a hammer or your thumb with a hammer, that hurts a lot, but not so much as if you have your hammer, if you have your thumb cut off in a buzzsaw. So the extent of the injury is very important, but even perhaps more so, the nature of the tissue that was injured. For example, the mid-back or trunk area has far fewer sensory fibers and far smaller part of the cerebral cortex devoted to interpreting pain than does a finger. And the finger has many more pain fibers. So we all know that it hurts a lot more to stick a needle in the finger than it does in the mid-back or trunk area, let alone the cornea, which has the highest number of sensory fibers of any tissue in the body. So the other aspects of the physiological experience of pain, it can be partially ablated. It can be locally decreased by ice packs, for example, or partial numbing agents such as menthol, methyl salicylate, camphor, oil of wintergreen, other things such as this that can partially numb the pain. Or we can inject xylocaine, pontocaine, procaine, ibucaine, and block all the pain sensation during its period of activity. So we have the physiologic aspects of pain, depending on the extent of the injury, the nature of the tissue that was injured. And then we have these affective aspects. The experience of pain varies in different individuals. It's just the way we're wired, and at different times in the same individual. Whereas other sensory thresholds of the body are more similar from one person to another. We all have sensory endings for touch, for pressure, or for proprioception, where we know where our body is at any given moment. That's the most important sensation we have. That takes precedence over all others. We have to know where we are. That's even more important than acute pain. But these tend to be quite similar across individuals, whereas the experience of pain tends to be very different. And finally, we have the evaluative aspects, our learned interpretive responses to pain. This is one of the things we learned growing up, how to react to pain. We have our cultural influences. We talked about the contrast versus those people in the Middle East and those in Northern Europe and Scandinavian countries. And then we have our own family influences that are surrounding us as we're a small child and learning what we learn about the world, and our own individual responses, including our personality, emotional issues, and I would say personal hardiness or self-control. Let's talk about the physiology of pain for a minute. We have the neurochemical aspects of pain that make it better and those that make it worse. We have these pain-diminishing endogenous opioids. They are polypeptides that are very similar to opium, and they're secreted by the neurons in the central nervous system in the brain and the spinal cord and the dorsal columns alongside the spinal cord. The beta endorphins we're familiar with, of course. A lot of work has been done with acupuncture showing how acupuncture releases beta endorphins in the central nervous system, and enkephalins and dynorphins, many times more powerful than morphine, molecule for molecule. And morphine sulfate is the most powerful pain drug that you can give a patient. And it is my favorite drug of all time because of its ability to control pain when nothing else will. Then we have the pain-enhancing substances, also peptides, released at the site of injury. Bradykinins lead the list because they are, more than any of these others, the chemical transmitters of pain, as the nociceptors are the neurologic transmitters of pain. Prostaglandins enhance pain in the area where tissues have been injured. Substance P enhances pain. Histamine, as you may know, enhances pain. And curiously, serotonin enhances pain. Students have often asked me when we've talked about pain in some of the classes that I teach, why is it that serotonin would enhance pain? Serotonin is a feel-good molecule. It's an amine. It's a feel-good amine. And yes, that indeed is true. It makes you feel good. It gives you a greater sense of mastery and coping skills. But if you're being attacked by a saber-toothed tiger or a cave bear, you want those coping skills, but you also want full awareness of any pain you're experiencing. And probably for that reason, evolving over millions of years, serotonin does enhance pain so we can deal with the circumstances that we're facing. We also have these cytokines released by white cells that really make us sick. They're the ones that make us feel sick when we get a cold or the flu or when we have pain. They make our temperature go up. They make us feel malaise. We want to go to bed. It's the white cells that do it so that the body has a chance to get better. It can heal better if we're lying down and resting than if we're running a marathon. So these cytokines are secreted by white cells, and they enhance pain sensation.
So, Bruce, could you please tell us a little bit more about what substance P is?
Yes, substance P is a polypeptide that's recently been discovered. It circulates in the bloodstream, in the spinal fluid, and particularly in the tissues. It's released by the capillaries into the tissues after an injury, and it makes pain feel worse. It just, should I say, jazzes up the whole biological mechanism of pain sensation. And so it's quite a breakthrough that recently this substance P has been noted in the cerebral spinal fluid of those with fibromyalgia, because they definitely seem to have an increased sensitivity to pain. So whenever somebody who has fibromyalgia undergoes surgery, it's a real trial for that person more than someone who does not have that problem, because they experience so much pain. And we think it's probably because of substance P. So here's a nice slide from Price's Pathophysiology textbook showing this mechanism. This big arrow here on the in the first drawing could be a hammer blow to the thumb. Let's say that it is. So this hammer blow to the thumb causes a release of potassium. That's the first thing that happens. It was released from the cells. Potassium mostly resides within the cells, as you know. It's released into the extracellular fluid, and that causes the chemical formation of prostaglandins and bradykinins. Bradykinins come out of the capillaries. Prostaglandins come from the tissues. Then the nociceptor fires, and you experience the first experiences of pain. And then as a result of the reflex mechanisms that occur that we'll talk a little bit more about later, we have then substance P. And substance P circulates around the body and affects the brain, and it causes us to feel more pain. We have histamine released from the mast cells, and the platelets release 5-hydroxytryptamine, otherwise known as serotonin. So we have serotonin, substance P, histamine, prostaglandins, and bradykinins, substance P, all circulating, causing the sensation of pain. Here's a very nice drawing also from Price showing the nerve fibers that register pain. We have these large pain fibers that run in the sensory nerves. However, this big one here has nothing to do with pain. That's the A alpha fiber that has to do with proprioception. And the smaller A delta fiber has to do with pain. That's a myelinated fiber so that the pain sensations get back faster if there's myelin on the nerve. So this is the first pain fiber that lets the brain know that the person's experiencing pain. Then we have this C unmyelinated fiber for slow pain, particularly active in chronic pain. And then another unmyelinated C fiber that registers the sympathetic nerve reactions to the injury or to what's going on in the tissues. And these two firing together have a role in reflex sympathetic dystrophy, as we mentioned earlier. So it's curious, isn't it, that the largest fibers, once again, have to tell us where we are. We've got to know where our body is and what it's doing in space, even more important than knowing whether something is hurting or not. Then we can process what is hurting a little bit better. So we have now, to complete the neurologic drawing here, we have this pain sensation going into the dorsal horns of the spinal column where the gray matter is. This is the white matter out here. This is the nerve tracts that surround the gray matter. And so we have the pain sensation coming in here, crossing over to the opposite side and going up the spinal thalamic tracts into the reticular formation, and also then into the thalamus. All of these first land in the thalamus. The thalamus is the big center in the diencephalon in the interbrain of the body that registers pain first. And we might say that this part of the brain decides what to do about it, whether or not to notify the cerebral cortex, which is the only conscious part of our existence, is out here. This is all unconscious or subconscious. And so the thalamus may subconsciously decide what to do, or it may notify the cerebral cortex where we're having pain here. So we have all these different parts of the cerebral cortex in the post-central gyrus that are dedicated to interpreting pain. So we have here a schematic drawing of the major areas of the brain, the frontal lobe, the somatomotor cortex in front of the central gyrus, and behind it, the postcentral gyrus, behind this big fissure here, we have the somatosensory cortex. And then the parietal lobe interprets what is experienced here. What's the meaning of this pain? The occipital lobe is very much dedicated to vision and interpreting visual stimuli, and the temporal lobe has to do with meaning and feelings and emotions. And so it all goes together. And then we have the medulla oblongata, the spinal cord of the cerebellum, which is our organ of balance. However, a curious thing occurs over the millennia. The sensory cortex has evolved, whereas tremendous areas are devoted to the face. Look at the lips. How much of the sensory cortex is devoted to the lips and to the tongue and also to the hand, particularly this finger, the index finger and the thumb and the rest of the hand. So the hand has as much sensory cortex gray matter interpreting pain as almost all the rest of the body put together. Look how little has to do with the shoulder. So when we have shoulder syndromes like a torn rotator cuff injury or a frozen shoulder syndrome, that pain will sometimes rotate around. And the best explanation for that, sometimes people say, why am I having pain in my upper arm when my problem is in the shoulder? Well, the reason for that is that there's so little area dedicated to interpreting pain. That's what they're talking about, is their interpretation of their pain. It's just that little spot right there. That would not be true if the pain were on the lips, for example, or in the hand. So you can touch a person with two pins very close together, 1 centimeter together in the fingers, and you can tell the difference between them. Whereas if you touch the shoulder with 2 pins 1 centimeter apart, it feels like 1 pinprick. You don't have the discrimination there. Very interesting, I think. But look how much sensation is devoted to the lips. So we can see the cultural evolution of kissing. So I put this slide on because it's so beautiful, showing these areas of cortical processing. But this one gives more information. Here's the post-central gyrus that interprets pain 1, 2, and 3, and then receives the pain, and then interpreting it here in 5 and in 7. This is the motor cortex that tells the muscles what to do. And so I've actually listed some of these for your interest. Primary motor area, the 6 and 8 eye movements, and out in the front there. And personality, primary sensation receptor area. I'll go back and forth here, 1, 2, and 3. And the integration of sensation perceptions, 5 and 7. Look at this huge area in 40 and in 39. 40 is interpreting touch and integrating it with language. Holding a pen and writing a letter has to do with interpreting touch, proprioception, and writing perhaps the characters for the King James Version of the Holy Bible 1,000 years ago or 400 years ago. So we have grasping the symbolism of written and spoken language and integrating touch sensations. Perceiving and understanding sound. I've mentioned some of the rest of these for your interest. And I just couldn't resist showing this slide, phrenology, 1848. So G.S. Fowler, who is the great proponent of phrenology, it was interesting how popular phrenology was, as it was a pseudoscience. This was based on the bumps on the surface of the skull. And they actually interpreted character as well as all these things like the area for falling in love or the area for having arguments or disagreements or fights. It shows you that this was popular throughout much of the 1800s because we have a strong craving to understand what's going on, even if we get it wrong. But maybe this led, in a way, to this. So there's a major problem with the way the human body is wired for pain that I wanted to mention this morning. It's heartbreaking, it's intriguing. Most nociceptive pain fibers are on the surface of the body organs, not in the inner part, which is known as the parenchyma. Thus, all pain fibers in the brain itself are on the surface in the meninges. None in the brain tissue itself, which feels no pain. There are no pain fibers in the parenchyma or the parenchyma, if you will, of the lung, the liver, the kidney, the ovaries, the pancreas. This makes cancer in these organs so serious and potentially fatal because it grows silently without pain, often until too late. The gate theory of pain modulation is the next topic we're going to talk about. There is this gate-like mechanism studied by Melzack and others in the dorsal horns of the spinal column known as the gelatin substance, or we use the Latin term, the substantia gelatinosa, which is pretty close to the English term. And this gate controls the flow of pain sensations. They go through and on up to the thalamus and then to the cerebral cortex. Initial pain sensations do get through. They go up to the limbic system, and then the limbic system communicates with the cortex. It can also stimulate a descending inhibitory system. So this descending system goes from the limbic system down to the dorsal horns and into the substantia gelatinosa, or the gelatinous substance. Then these structures moderate pain and close the gate. So the terms we use: closed gate, pain sensation is blocked. Open gate, the pain gets through to the thalamus and onto the sensory cortex, and we experience pain. This is showing some of these pain fibers, how they go up and how they, in the medulla and in the midbrain, they're interpreted, and then also in the periaqueductal gray in the thalamus. uh, in some of the limbic areas down here in the cingulate gyrus and the hippocampus, and then on down to the just substantia gelatinosa, up and then back down. So we have another drawing showing this even better. Interpretation of pain and the perception of pain, and the ultimate interpretation of pain also has a lot to do with the frontal cortex, which are our main conscious centers, and what are we going to do about this, and how bad is it, and how much is it bothering us, and how much control do we have over it, and how much can we ignore it. All things we're going to talk about this morning. And then we have the descending impulse from the base of the brain going down into the substantia gelatinosa. And there is then an enkephalon release by this interneuron, particularly enkephalon, that causes less pain if the gate is blocked. So once again, I just wanted to show the anatomy of it. We have this spinal cord view with the gray matter and the white matter. But this is the dorsal part of the spinal cord up here where I'm pointing now. So we have to turn the body over. So when we turn it over, Frank Netter gets confused and he does everything upside down. But we have here the spinal cord the way you're used to seeing it, with the butterfly shape of the gray matter, and then the white matter, the columns here of nerve tracts. These are sensory nerve tracts. These are motor nerve tracts here. These are extrapyramidal nerve tracts down here. Just wanted to show you where it fits in the body itself. Once again, a blow up here showing the gelatinous substance, all this gray matter, and then the white matter here. So just as a double check on the physiology of this area, I've included another wonderful slide showing, I really like this slide myself, showing the gray matter, and then all the tracks in the white matter. These are the sensory tracks. This is the dorsal columns, the gracilis fasciculus and the cuneate fasciculus. And then these spinal cerebellar tracts. And then we have the motor tracts, the corticospinal tracts that make our muscles work, and the extrapyramidal tracts that help fine-tune the refinement of muscle contraction. So the gate theory, the final result of all of this physiology is that anxiety, worry, depression, focusing on an injury or an illness may open the gate and increase pain. And meditation, relaxation, positive emotions, acupuncture, hypnotism, or distraction close the gate and decrease or possibly even block pain. I couldn't resist putting down as an asterisk the dentist that I knew. He was the one that I went to for years. He projected Groucho Marx movies on the ceiling of the dental office. And he also projected Bugs Bunny cartoons for kids because they don't get Groucho Marx, of course. But Groucho Marx are some of the funniest movies that have ever been made. So this sensory decision theory, the actual experience of pain, is interpreted in the sensory cortex. So both of these theories, I think you're already realizing as I discuss this, are operative. So this actual experience of pain is influenced by many things. We've already touched on some of these today. Activity at the time, such as running a marathon or fighting. Attention versus distraction at the time. Whether circulating endorphins versus pain-inducing substances are predominating in the nervous system. And the expectancy of pain. We have previous memories of going to the dentist. We call it the going to the dentist syndrome, where we fear the previous pain, and that sets us on edge. So we're going to experience more pain this time than we otherwise might. So this is, in a sense, a form of the torture syndrome. Fear, anticipation of severe pain, the lack of control when someone is doing something that's very painful to you that you have no control over. You feel tortured, let alone someone who is tortured. And then once again, these omnipresent cultural and sociological influences, like I had mentioned earlier. Other things that are very important are the person's degree of self-control, his ability to minimize the pain experience in his mind. We talked about that a minute ago. The chronicity of the pain experience. Severe chronic pain can wear the hardiest person down. And also the meaning of the painful event to the person. Some great purpose may have been served by the pain. Excuse me. Joan of Arc, who was burned at the stake. The story of Braveheart, who was tortured. William Wallace, you know, who opposed the British in the 1200s. Medics who are injured while taking care of other soldiers during battle and that keep going. There are so many amazing stories. I always enjoy reading the Medal of Honor stories. People who in the United States are awarded the Congressional Medal of Honor, and I'm sure um, in Australia and New Zealand they have similar medals. So I love this quote by Kalinke. It is wise to differentiate pain as a sensory event and the experience of pain and the experience of suffering from pain. Chronic pain and acute pain. A very good slide, I believe. Onset and duration. This is from Price's textbook of physiology. Abrupt onset, duration short, acute pain, and chronic pain gradual. This is an arbitrary amount, 6 months, but just in general, abrupt onset with a duration short over days or weeks, and gradual onset. Intensity, moderate to severe, intensity the same, moderate to severe. The cause is specific, biologically identifiable, or it could be trauma, but it's definitely identifiable. And here the cause may or may not be well defined. The physiologic response to acute pain is the sympathetic discharge, hyperactivity, increased blood pressure, increased pulse, respiratory rate, dilated pupils, pallor, perspiration, nausea and or vomiting. But with the chronic pain, the autonomic activity is not turned on or not changed. The emotional and behavioral responses are very different. This person is anxious, unable to concentrate, restless, distressed, but optimistic about the relief of pain. We'll hope so. And here, excuse me, the depression and fatigue, immobility or physical inactivity, social withdrawal. Depressed, feels no relief in sight, expects long-term pain. Response to analgesics, effective pain control. And response in chronic pain, often ineffective pain relief. Pain and personality are interesting to me. Personality can predispose to pain, perhaps. There's certainly a role of the operant conditioning that's well described by B.F. Skinner, reinforcing the behavior. As you know, his theory of behavior is based on rewards and punishments. And that is that a reward reinforces a behavior and makes it more likely to occur again. And a punishment tends to extinguish a behavior and make it less likely to occur again or to be experienced again. So the crucial factor here, we have obvious rewards for being in pain. Sympathy, we all like that, or at least we receive it positively. It's probably not good for us. Intense concern, we do like that. And relief from work or school responsibilities. Or is the patient rewarded for shrugging off the pain, for being strong and for rising above it? So the rewards here are very important, and we'll come back to that in terms of treatment later on. This process can settle in and can affect a person's way of being. We have a special case of Munchausen syndrome, people who seek rewards for pain or who may intentionally injure themselves to receive these positive benefits of pain or for possibly reasons that we don't fully understand. We have the even more tragic Munchausen by proxy syndrome, where parents will injure their children so they can get attention and sympathy because they have a child who's been injured. Personality studies, we have this famous test that's used all over the world and very popular in the United States, Canada, Great Britain, Australia, and New Zealand. The MMPI 1 and 2, the latest version is the MMPI 2. The Minnesota Multiphasic Personality Inventory. It's a 4-hour test. It's often part of a psychologist's workup for his or her patients. It identifies these scales as the test evolves over the 4 hours. The person who is taking the test answers all these questions like, do you feel angry when other people go out to dinner without you? Um, that's a pretty obvious one. Uh, do you prefer the morning or the evening? Are you generally a happy person or a sad person? And how do you feel when you first wake up? All these sorts of questions. And there are many more subtle than that. And they evolve these scales. One of the scales that evolves with this 4-hour test is how much we tend toward being hypochondriac. So we're all on a spectrum of 0 to 10, where 10 is extremely hypochondriacal and 0 is not at all. But we're somewhere on that scale, and so this helps to determine. So how hysterical are we, or is the person that's taking this test? Do we overreact to events that tend to threaten us or that occur to us, or do we underreact to them? Or do we tend to be depressed or not? So people who are high on these scales tend to have more chronic pain and tend to react more intensely to acute pain. Those who score high on these neurotic scales, these are called the neurotic scales. Some have argued that it's the neuroticism that causes acute injuries to turn chronic. But clinical injury evidence tends to point the other way, folks, that chronic pain causes the neuroticism. Because when long-term pain is relieved by therapeutic intervention of some sort, scores in the neurotic triad and anxiety fall, often back to normal levels. And self-esteem, which is often low in chronic pain patients, shows improvement once the pain has resolved. So which comes first, the personality problem or the pain? We have this famous example of King Henry VIII with his painful and foul-smelling decubitus ulcer in his later adult years, where some of his wives would say things to him like, "It was a horrible experience to be in bed with you." Well, if you said that to King Henry VIII, he probably would lop off your head. And so he did. So the answer, though, is that it's a complicated interplay, but often the pain comes first. So I love this quote by David Bresser, who works in the UCLA Pain Center in Los Angeles. Many patients suffer from pain, and those who do must confront the unpleasant question. Is it your pain that makes your life unbearable, or is it your life that makes your pain unbearable? Special concern is with children. Not only may the pain be intense, but it may be accompanied with intense fear with children. Children often have fear lingering under the surface, waiting to erupt into consciousness. Little kids, before they go to bed at night, look under the bed to make sure there's no boogeymen there that might come out and grab them. They have limited understanding and even less control over things that are important, things that might hurt them. And of course, there's also a wide spectrum here in terms of how fearful the child is versus how much in control of his or her fear. But pain is difficult for children because they don't understand it. What does it mean? How long is it going to last? Am I dying? I can't stand this. Fear in childhood can be extremely intense. Adults know more, understand better, and potentially have more control over their lives than children do. And with adults, the problem often becomes a case of knowing too much. They understand how others might be hurting them or trying to hurt them. They may understand the difficulty of extracting themselves from a life situation that's recurrently painful. They may ruefully recognize that life is demanding, life is tough, and in the final analysis, there's no free lunch. So this is a famous painting that you may have seen by the Norwegian painter Edvard Munch. The scream. Although this person is screaming with an abject horror. Is this person seeing something on the walkway that's scaring them? I doubt it. It looks like a beautiful walkway. And to emphasize the fact that that's probably not what's happening, we have two other people here who are strolling along, reflecting on their lives in probably a positive way. This person is reflecting on his or her life and is screaming. In his book, The Greatest Show on Earth, biologist Richard Dawkins, a British anthropologist and biologist who teaches in Great Britain, grapples with the question of why pain has to be so painful and so totally unpleasant. He describes the alternative might be just simply a red flag. Hey, this is bad, telling the person to pay attention to something. But he's thought very carefully about this, as have many biologists who have studied Darwin's theory of evolution and how it evolved. So to argue why such a red flag might be insufficient, he explains that drives within living beings must compete with each other for attention. So the most fit creature likely to survive would be the one whose pains are well balanced with the threats that are out there. So those pains which mean certain death, when ignored, will evolve to become the most powerfully felt. The relative intensities of pain, then, may resemble the relative importance of that risk, at least to our ancestors. Thus, a lack of food, too much cold, or serious injuries that are felt as agony because these are threatening to our life, whereas minor damage is felt as mere discomfort. So if you want to recall or experience how painful too much cold is, immerse your arm in ice water for a minute or so. In fact, when I say a minute or so, you won't be able to stand it for a minute. You'll have to pull it out before that, I imagine, because by then the pain is agonizing. And a lack of food when you have severe hunger, which few of us have experienced, can be similarly agonizing, I understand. Therefore, our pain reception has become designed to prioritize the dangers to our body. Important pain syndromes we'll talk about then for a few minutes. Headaches. Vast millions of people have severe recurrent headaches. 30, 40, 50 million people in the United States. Migraine headaches are very common, occur mostly in women, and they're often throbbing headaches, although not always. They're often accompanied with an aura, where just before the headache begins, the person sees flashing lights, or may have a strange smell, or may hear unusual sounds, or feel nauseated. That's called an aura. And migraine headaches, of course, can occur without an aura. The classic one is a unilateral throbbing headache that becomes so severe that the person has to get out of the light and go into a dark room and stay there all day. Cluster headaches are more common in men. Migraine headaches often tend to affect women in their 30s, 40s, or younger, or a little older, where cluster headaches are a condition of middle-aged and older men in their 50s, 60s, 70s. They're clustered around days of the month. That's why they call them cluster headaches, because they occur 3 or 4 times a month at the end of the month, for example, and they're associated with histamine release. They often occur at 3 or 4 in the morning, and they're behind one eye. They're associated with a running of the nose and a nasal congestion, also due to the histamine release, sometimes an itchiness in the hard palate from the histamine. And they are agonizing and near suicidal headaches. They're so severe. Tension headaches tend to be every day, or most days, occurring in the afternoon, coming on like a vice-like grip around your head as you're at work and you'd like to get back home and you can't stand the tension. Depression headaches tend to be in the morning, and you wake up with them and you have this very dull, severe headache that goes along with the bad experience of waking up at all, because it's another miserable day for you. Brain tumors are far less common than these other causes of headaches, and they have associated signs and symptoms. So a good physical examination and a good history, more than anything else, differentiates these headaches so that CT scans and MRI scans, which are so routinely ordered when a person goes to see a doctor about a headache, are not necessary most of the time. We spend billions of dollars a year on these scans when they are not needed. Now, sometimes they are needed, but you get my point in terms of how these often can be diagnosed without an imaging study. Chronic pain syndromes include low back pain, chronic neck pain, two of the other biggest sources of referrals to acupuncturists. Many millions are afflicted with one of these, with a significant number chronic disabled. Ruptured discs can cause this, with pain radiating down the leg or an arm if it's a cervical disc. Vertebral misalignment or bone spurs with nerve compression. Severe rheumatoid arthritis or lupus or ankylosing spondylitis can cause this kind of pain in the lower back or in the mid-back as well, but mostly in the lower back or in the neck. Spinal stenosis building up over the years, also causing nerve compression and pain in the back and radiating down an arm or a leg. Tumors, of course, can cause lower back pain. Carcinoma of the pancreas patient, the one that sticks in my mind, is the one who went to the chiropractor because he had back pain, and the chiropractor treated him with manipulations. I have some chiropractors that I love and deeply respect, and I go to see them myself, but this one did not do a good job. He never asked the person, have you lost any weight? Part of the normal history workup of any patient, because the person would have said, this patient would have said, yes, I've lost about 18 pounds, and I don't know exactly why. I wasn't trying to lose this weight. That should be a red flag. So by the time the person had lost 30 pounds, the chiropractor said, you don't look very good, Fred. I'm worried about you. And Fred says, well, I feel terrible. So he sent him to a physician who diagnosed cancer of the pancreas, and by that time it was too late. He died in a hospital in Mexico trying to get Laetrile treatments. I knew the story of this man. I knew this man. Fibromyalgia, vast number of patients with these pain syndromes, as we mentioned earlier. Stomach dyspepsia with recurrent epigastric pain, very common, and then lower down irritable bowel syndromes with recurrent mid and lower abdominal pain. Facial pain syndromes are very common. The worst of them is trigeminal neuralgia and postherpetic neuralgia. I want to talk about both of these because you see them so commonly in your acupuncture clinic. Trigeminal neuralgia, known commonly by the French term tic douloureux, especially affects middle-aged women. It affects the second and third divisions of the fifth nerve. One-sided stabbing pain starting at the corner of the mouth, shooting up towards the eye or ear is typical, or sometimes starting in a tooth or settling in a tooth. Brought on by touch, movement, drafts, eating, or just simply can occur recurrently and is very severe. It can progressively get worse over time. The cause may sometimes be due to a tortuous blood vessel that's compressing the nerve root and eroding the myelin sheath and causing this pain. So here's the Gray's Anatomy famous drawing of the trigeminal nerve showing the first, second, and third divisions. It's these two divisions that are affected. You can see blood vessels around here, but it doesn't show them all. But these blood vessels, particularly cerebellar vessels, can compress the second and third divisions of the nerve. Diagnosis is based on the history because the exam is normal between attacks. Imaging studies are normal. For drugs, we use anti-seizure medications such as Dilantin and Tegretol. Excuse me. Acupuncture and herbs are very effective for trigeminal neuralgia. Many patients go to a neurosurgeon and they receive a laser rhizotomy or a severing of nerve roots or a radio frequency ablation, also known as a rhizotomy. A surgery with separation of the pulsating blood vessel is known as a genetic procedure. 96% success rate in this operation in the short term. But in the long term, many recurrences, a high percentage of recurrences. This person's experiencing severe pain, and it feels like it's killing her. When possible, I love this, so I had to put it into the slides. Use acupuncture or herbs rather than Western drugs. Absolutely, although I'm a Western physician, I'm totally committed to that idea. Postherpetic neuralgia, due to nerve damage caused by herpes zoster, also known as shingles. We now have a vaccine available for those over the age of 60, known as Zostavax. The damage caused by nerves in the affected dermatome area of the skin send abnormal electrical signals to the brain. These signals may convey excruciating pain and may persist or recur for months or years or even throughout the remainder of the person's life. In the United States each year, I wanted to give you these demographics. 1 million people develop herpes zoster. Most are over the age of 60. A similar incidence and percentage in Australia and New Zealand. Approximately 20% or 200,000 individuals in the US develop this postherpetic neuralgia, a very high percentage, unfortunately. This becomes chronic because of the changes that occur in the dorsal ganglia of the sensory nerves that perpetuate the pain. The measure of pain. Many physiologic measures have been studied. Muscle tension with pain. Muscle tension certainly goes up when the person's experiencing pain, but there are no predictable correlations between the tensometer readings and pain. Unfortunately, although you might expect it would be reliable, it's not. Autonomic indices, since we do have an increasing heart rate, respiration, sweating, dilated pupils, no good correlation has been found in studying this. People have such different responses. Evoked potentials on the electroencephalogram. There's been no reliable correlation. The most promising area of all these has been thermography, decreased temperature in the painful areas. This shows the greatest hope of some correlation with the actual amount of pain felt by the patient. Thermography has a hopeful future diagnostically and therapeutically in our country. Behavioral, and in our countries, I should say. Behavioral assessment has also been done, observation by others of those in pain, since we all note people who are in pain, and we can tell that the people around us may be in pain or not. So a famous study was done of 2,000 patients, and their behaviors were analyzed: guarding, wincing, position changes, moaning, or crying. And the results were no reliable correlation between the complaints of pain or the responses to pain and apparently actual levels of pain. So we are left with self-reports. These are subjective, whereas these others are objective. However, these work the best. They're much far more helpful because they report what the person's actually experiencing. And we've talked today about all the different things that can get in the way of experiencing pain, make it worse, or make it less intense. We start off today on our discussion about this with these pain measurement scales. The best known is the Harvard scale. Here's a typical scale: no pain, dreadful, horrible, or agonizing. So it's a very, very common experience in the hospital when you're a patient. I've recently been a patient in the hospital with both neck surgery and back surgery from my spinal stenosis, and I'm doing fine, thank you. But the nurse would come in every day and she would say, "So, Dr. Robinson, on a scale of 1 to 10, how much pain are you having today?" And so when I first started off and I was in severe pain, I would say, "Oh, it's a 7 or an 8. That would get her attention. But I'm sure this was not true. We don't really know how intense or severe a 7 or 8 pain is. Now, with my nerve compression in the neck, I did have, I would say, an 8 or possibly even a 9 pain. It was so severe, I could not stand it. I couldn't bear it. I had to have a morphine drip. I'm a physician. I was in a mountain town when this happened. And so the woman whose home I was staying in, I asked her, "Do you know anybody in this village that has cancer?" who has had cancer? She said, yes, I do. She said, well, such a person will have either some morphine or some OxyContin or some Demerol or at least some hydroxycodone that I can have until I get to the hospital. Please get it for me. And she did. She found some oxycodone. That helped slightly until I got on a morphine drip. But that's all in the past. But these pains, the Harvard Pain Scale, in fact, shows you how severe pain can be. So when people say, when you ask them on a scale of 1 to 10, they're having a headache, they say, I'm having a 10. I don't think that's probably true, but it might be. So you can see 1, 2, and 3 are various degrees of minor or moderate pain. Well, I should say minor pain. Moderate pain, 4 to 6, distressing. Strong, deep pain is a 4, like an average toothache. That's unpleasant. 5, very distressing. Strong, deep, piercing pain, such as a sprained ankle when you suddenly stand on it wrong. That really hurts, doesn't it? But that would be a 5, folks. Or mild back pain. Back pain can be terrible. Intense, a 6 pain. Strong, deep, piercing pain. So strong it seems to partially dominate your senses, causing you to think somewhat unclearly, perhaps. You have trouble doing your normal activities and maintaining your normal relationships with a 6. Now these are the worst, 7 to 10. 7, unable to engage in normal activities. The patient is disabled by the pain. 7, very, very intense. 8, utterly horrible. Suicide is frequently contemplated and sometimes tried, comparable to childbirth or a very bad migraine headache. Excruciating and unbearable, so intense you cannot tolerate it and you demand painkillers or surgery no matter what. Well, my neck pain might have been close to a 9, but 10 is the pain you have when you cut your hand off in a power saw and you lose consciousness, not because of the blood loss, but because of the pain. So it's instructive, I believe, to go over these and to realize how severe pain can be. And we go back to the very beginning of this presentation when we ask, why do we have to have it if it's so terrible? But we've tried to answer that. We do need to have it, unfortunately, but true.
Sorry, Bruce,
Yes.
Just a question about the pain scale. And, what's your opinion about some of the cultural and individual different relationships to that scale, given the subjectivity of experiencing pain?
I would say that's a very good question, Kath. I would say that people who have the cultural predisposition from Scandinavian countries, we've given that example today, or from anywhere where pain is minimized and people are told to ignore pain if possible, that they would actually experience less pain because the gate theory would operate and they would have this release of these enkephalins in the substantia gelatinosa and the dorsal horns of the spinal cord, and they would actually experience less pain. So it would move their pain down to a lesser degree of pain.
You're differentiating between the sensorial experience of the pain versus the emotional distress that the pain actually causes.
They tend to go hand in hand. If the emotional distress is intense, then the actual perception of pain gets worse, from what we can tell. So it's a vicious cycle. So the person who tends to react intensely to pain and has an emotional response may be overdoing it emotionally if they have Munchausen syndrome, or if they have a personality disorder where they're trying to get attention, a histrionic personality, for example. But they may actually be making their pain worse because they're reacting so intensely about it.
And certainly from a clinical point of view, a person walking into an acupuncture practice in distress, in severe pain, perhaps an acupuncturist might look at treating some of the emotional aspect of the pain and then looking at perhaps resolving some of the underlying causes. That's where acupuncture can play a very effective role in treating that.
Absolutely. And I think One of the keys to this whole process that you're talking about, Kath, is the medical history. The medical history establishes your relationship with the patient and calms the patient. Uh, After a good medical history, the patient has all those big C's. The person is cooperative, calm, collected, and they have more confidence in you. And so this is a wonderful tool that you have. When a person goes in to see the Western medical doctor in our healthcare system, um, they have far less time for their medical history. Usually they fill it out in a form in the waiting room, and the doctor goes over that for a couple of minutes. He focuses on this or that you've checked off. You've had asthma in the past. Okay, well, let's talk about that. You had a kidney stone. Let's talk about that for a minute or so. But then they're over it, and they're getting into why you came to see them. So the average length of time of a doctor visit ends up being about 8 minutes. And you spend an hour with this person, you get a chance to do all those positive things that you're talking about. And we'll come back to some of those, Kath, later on also in this discussion as to how you can help people deal with their pain in positive ways to make it less, and also at the same time to enhance their coping repertoire. So the McGill or the Melzack Pain Questionnaire, uh, worked up by Melzack and Walls in Canada, the best precise measurement of perceived pain so far, 80 different descriptions of pain organized into 20 categories. The focus on this descriptor is what the pain is like in terms of its specific qualities. So I've listed some of them that the McGill, I call it the McGill Pain Questionnaire. Flickering, because McGill University is where it was developed. Flickering, jumping, pricking, sharp, pinching, tugging, hot, tingling, fearful, tight, nagging, plus many others. Here's a drawing of this McGill Pain Questionnaire. So these are organized into these 20 categories, and each one are different levels of intensity of that same quality. Let's take number 5, for example, pinching, pressing, gnawing, cramping, or crushing. Let's take number 3, where if the pain feels like something is being stuck into the patient. Pricking with a small needle, boring, drilling, stabbing, or lancinating, being run through with a lance. So also you can indicate on this pain questionnaire where the pain is, whether it's external or internal, and you can make comments about the pain. You can talk about whether it's brief, momentary, transient, rhythmic, periodic, or intermittent, or whether it's continuous, steady, or constant. Those are pretty close to the same. So this is a very good tool for you to use. You can download this in your pain clinic, and many of you, I suspect, may be using it. As to the nature of the pain, trying to break the gap between the subjective interpretation of pain and the objective reporting of that pain so that you can get a handle on it and can understand how this pain is and what it's like for that person. So we have the McGill Pain Questionnaire, and we have other well-known pain reports, the most famous of which I wanted to mention was developed at Yale University, the Yale Multidimensional Pain Inventory. And this is a completely different approach that's equally important, the social aspects of pain, how it affects your job, how it affects your activities, how it affects your relationships, and how it affects your enjoyment of life. So I've shown some of this. This is a long questionnaire, 10 pages long, but I've shown some of these. First of all, you establish your significant other. And I'd just like to read this to you. Some of these questions in this questionnaire refer to your significant other. A significant other is a person with whom you feel the closest. This includes anyone that you relate to on a regular or infrequent basis. It is very important that you identify someone as your significant other. Please indicate below who this might be: your spouse, a good friend, somebody else, a partner, a neighbor, a housemate or roommate, a parent or a child or other relative like an aunt or an uncle. Do you currently live with this person, yes or no? In this following 20 questions, you'll be asked to decide about your pain and how it affects your life. You rate the level of your pain. This one is on a scale of 1 to 6, with 6 being very intense pain. In general, how much does this pain interfere with your life and with your day-to-day activities? And since you had this pain, how much has it changed your ability to work? How supportive has your spouse or your significant other been in relationship to your pain? So you can see where this fits in. Rate your overall mood. On the average, how severe has your pain been during the last week? How much has it changed your ability to participate in recreation or social activities? And the amount of satisfaction you get from your family-related activities. How worried is your spouse about you? During the past week, how much control do you feel you've had over your life? How much suffering do you experience because of your pain? How much has your pain changed the amount of satisfaction or enjoyment you get from your work? How attentive has your spouse been to your pain problem? How much has your pain changed your ability to do your household chores or your personal chores? How irritable have you been? How tense or anxious have you been? How it has affected your friendships? All of these things are so important, and you can sort them out in your dealing with your patients as pain, chronic pain affects their entire life. So long-term studies with this Yale Pain Inventory, I did identify these 3 main adaptations with 1,000 variations, of course. Adaptive coping patients have learned how to coexist with their pain. Maybe it's not been easy. We're not saying it has been easy. Interpersonally distressed patients, they remain resentful. They tend to feel those around them fail to provide needed support. They may blame others for their pain, or they may blame God or their own karma, but they tend to be victims. Dysfunctional patients have great perceived pain. They have a low level of self-control. They have intense psychic distress. They tend to fall apart. Medical approaches to control pain. I'm a surgeon, so I spent my life dealing with pain, but usually from a secondary cause that I could treat, that I could remove. I could remove the gallstones. I could remove the tumor. I didn't do ruptured disc surgery or spinal stenosis surgery, but other orthopedic surgeons do this kind of surgery. Medications, pills, injections, patches, catheters. And self-controlled intravenous medication has been shown to be very effective. It's used successfully in hospitals around the world now, and in some hospice settings at home, where visiting nurses come and they set up this for a patient who has a very poor prognosis, usually with terminal cancer, and is being treated at home, which is the best place for people with terminal diseases. So self-controlled IV medication is wonderful. And they have found, curiously, that people who give themselves IV morphine or any of the other narcotic medications, such as Demerol, use a lesser amount than the nurses use to treat them. So they get lesser of this, and that's wonderful because it's less likely to form habits later on and less constipating, for example. That's a serious problem with narcotics, is its tendency to constipate the patient. Acupuncture and herbal therapy are very effective, of course, for treatment of pain, and we'll mention something about that that's a recent breakthrough in a minute. Excuse me. Physical therapy and transcutaneous electric nerve stimulator units, or TENS units. Ancient acupuncture needles going back thousands of years. People were anxious to ablate and take care of pain in those days. So the Neijing, evolving around 200 BC over a period of years up to maybe perhaps 100 AD, was the first, well, shall we say, scientific approach to dealing with acupuncture. But before that, we have long reports of acupuncture that were more related to releasing evil spirits or magical demons. But the Neijing was the first to have a scientific approach to the use of acupuncture needles, as you know so well. Recent studies on the effect of acupuncture with rats strongly suggest a mechanism for how this treatment works to reduce stress and facilitates coping in stressful situations such as severe pain. Acupuncture causes the reduction of neuropeptide Y, which is released by the body during stress. We've been studying for the last 25 years since we had this breakthrough in the 1980s of endorphins released in the brain. We've been studying other hormones than epinephrine and norepinephrine that are released during stress. And there are polypeptides in the brain. And we have neuropeptide Y that's released during stress. And this study may be an important breakthrough because acupuncture releases neuropeptide Y. So I think that we now need to do these studies in human beings. That's the next phase. But maybe we're going to be able to understand quite a bit more as to how this affects stress. And so I have here a quote that you might look up and then follow other quotes for this new breakthrough on acupuncture and how it may work in the human body. Neurosurgery for pain ablation. Chordotomy is a severing of tracts in the spinal cord. That's less often done than rhizotomy, the severing of nerve roots, because these nerve roots, as they exit the spinal canal through the foramina of the vertebral bodies, are compressed by tumors and by rupturing discs and by osteophytes and by misalignment of vertebra, and the nerve roots cause severe pain, and those can be severed. However, the patient gets numbness as well as pain relief when these nerve roots are severed, and the pain tends to recur after a couple of years, but the numbness remains. As draconian as that is, that tends to be what happens. New approaches implantation of these mini stimulators into the spinal nerve roots, causing neurons there to release more natural endorphins like enkephalins, dinephalins, and beta endorphins. These tend to work well for a while, and then patients build up a tolerance to them. They often cost $200,000, and insurance sometimes covers them if all other means have been tried to control pain, and sometimes not. Gene therapy is a very interesting new process I wanted to report to you. At the University of Michigan, researchers David Fink and Marina Mata have created gene therapy to block pain signals before they reach the central nervous system in the spinal column. They've constructed a non-infectious form of the herpes simplex virus, spliced with genes that release natural pain-killing opioids directly into the dorsal nerve sensory cell ganglion near the dorsal horn of the spinal cord, where the HSV virus travels, herpes simplex virus, and where it likes to reside. Herpes simplex virus tends to reside there. Herpes simplex oralis, herpes simplex genitalis, and the herpes zoster virus. All of the herpes viruses that cause pain tend to be chronic and tend to live in those nerve roots, as you know. So as the HSV carrier virus is ejected under the skin, it travels up to the axon of the nearby sensory nerve cell, and then it reaches the dorsal root ganglion, of the sensory cell, and then it releases the gene that has been inserted or spliced into the modified virus particle. Then this modified virus particle does a good job. It begins to express the natural pain-killing peptide that then interrupts the transmission of the pain sensations. Enkephalins, dynorphins. They can target specific sensory nerve areas. This is all done in one sitting of 10 small injections with a 26-gauge needle. I think this is a great breakthrough. And it results of the phase 1 clinical trials. Patients who underwent this treatment reported more than 80% reduction of their pain over the next 4 weeks. Imagine what that would be like for a post-herpetic neuralgia patient following the treatment with no adverse effects. So phase 1 trials are done on a smaller number of patients, usually 30 to 100. And phase 2 trials are done on thousands of patients in a double-blind setting with the placebo, comparing the treatment with the placebo. Phase 2 trials need to be done now, and further refinements of the procedure will be achieved in these phase 2 trials. And then phase 3 trials in multiple medical centers need to be done as well. This will take years, unfortunately, but that's what is needed. And hopefully these patients will then begin to initiate the opioid release on their own. And if they can move this through faster to take place in a year or two, that would be great, because it sounds wonderful to me. There's a great promise for post-herpetic neuralgia and for other neuralgia syndromes like trigeminal neuralgia and many other chronic pain syndromes as well. Here's a picture of the two researchers. I am actually an alumnus of the University of Michigan, and I have to say, as I'm presenting this slide, go blue. I shouted that in football games for years and years as I was a resident and also a medical student before that at the University of Michigan. But this is a great promise. Psychological treatment, we're going to finish up on that. We're getting through a very nice time. I'm happy about this. Psychological treatment and support of patients with chronic pain. There are definite factors that have been studied. Melzack and many others have studied these, and also Meichenbaum that I talked about early on in this seminar. Factors influencing the outcome of any psychological treatment, the level of personal sense of control that the person has. Are you a creator of your circumstances, or are you a creature of your circumstances? Steve Covey, who's written a lot of books on success, The 7 Habits of Success, initiated that term. Are you the creator or the creature of your circumstances in life? How much sense of control do you have over them? Those people who develop a stronger sense of control, who are not victimized by their circumstances, do better and respond better to these treatments that we're going to talk about. People who have more social support, those who are in loving relationships with a significant other, as the Yale multidimensional survey was so focused on. And then we have this level of personal hardiness, the ability to cope with adversity. How well does the patient cope with adversity? And how well do any of us cope with our own problems in life versus being put down by them? So probably this quality and this one are closely related. Motivation, how strong is the motivation for the person to get better? Or are they discouraged and depressed and they do not have the motivation? Spirituality issues are a very strong resource for many people in terms of improving and overcoming chronic pain, as they are for all of these 12-step programs for addiction that are so important for people to overcome their addiction to various substances like alcohol and drugs and things, and overeating. Techniques of psychological treatment I've listed briefly. Hypnosis. Mesmerism goes back to the 1700s, to Anton Mesmer, who first developed it and created it as a distraction for parlor games among the rich in France in the 1700s. The treatments of hypnotism are very varied, but they do bring the person into a state of compliance. About 50% of people tend to respond well to hypnosis, and the other 50% do not. Those people who tend to respond, who are suggestible, who are able to submit to someone hypnotizing them, benefit greatly from hypnosis, and it has a definite role. Relaxation training has a broader application. Progressive muscle relaxation techniques are wonderful. Meditation techniques help a great deal in dealing with chronic pain. Guided imagery, where you're focusing, where the person is guided through imagining processes going on in their body that are helping them, is a great help for chronic pain syndromes, as it's been shown to be a benefit in patients with cancer, as they imagine that there are processes going on in their body that are destroying the cancer cells. And the more you imagine that, the more it actually takes place through mechanisms that we don't understand. Biofeedback, auditory, tactile, or visual, tactile with a vibration particularly, measures temperature changes, heart rate, blood pressure changes with control of pain, thinking the pain down, moderate success in places where these are utilized and trained well, where the people who administer them are well trained. Biofeedback definitely deserves a place among psychological treatment methods. Behavior modification with operant conditioning to reverse the rewards of being in pain that we talked about. The person who is in pain gets sympathy, they get attention, they get relief from their work and their school responsibilities, and they get workman's compensation payments. Someone who is getting workman's compensation payments for an injury on the job is far less likely to respond well, and as long as they're getting those payments. And that's not just a practical thing, that is psychological as well. So we here come face to face with the distinction between malingering and with Munchausen syndrome. With malingering is faking pain or complaining about pain for a recognizable goal. And Munchausen syndrome, people fake pain and recognize pain for recognizable goals, but they don't really know the process of why and how they do it. But malingering people can be recognized quite often and dealt with. And I should say that we probably all have a touch of the malingering gene. How many of us, for example, have stayed home as kids when we maybe didn't feel too well, and we talked it up a little bit more to our mothers or dads, and we got to stay home and miss a day in school, and maybe if it was cold outside, sit by the fire and maybe get some hot chocolate. I don't know if you were ever guilty of that or not. So cognitive therapy changes the interpretation of the pain. But when we change the interpretation of the pain, we don't avoid it. We curiously go towards it, because that is how we gain control over it. So the idea is to control the pain and not let the pain control you. So in the process of doing this, we increase the self-efficacy beliefs. And a wonderful person who has developed this to an art is Jon Kabat-Zinn, one of the most wonderful people I've ever had the great pleasure of meeting and working with. And I studied with Jon Kabat-Zinn. And he does deep inner self-focusing. He does a lot of yoga that involves muscle relaxation and body scans that take you through your entire body, where you are aware of all body sensations. And when you get to a body part that is hurting, and that is in pain, you go towards that pain. You feel it physically in your body. You go towards that with your own spiritual energy, as it were. You are infinitely bigger than that pain. You can gain control of that pain. So his books on mindfulness-based stress reduction are very well worth studying. Jon Kabat-Zinn from the University of Massachusetts in Worcester. So technique of behavior modification for chronic pain syndromes. We'll finish up with that. And this is got here and is an asterisk. Let's go right down to the bottom there. It is not just for psychologists, where people go to psychologists who should be using this technique, although they certainly do. And it involves ignoring or minimizing your attention to the patient's pain behaviors, reinforcing well behaviors, providing optimism, positive outlook, and then increasing the activity level of the patient as they can tolerate it. So when somebody comes in with a recently sprained ankle, you don't say, "Oh, wow, you look so terrible. I'm so sorry. Oh, you must really be in pain. Oh, my." That's the very opposite. You say, "Wow, you seem to be limping there. What's going on? Wow, how did that happen?" Well, gosh, well, you do seem to be on top of it, at least to some extent. You're getting around, you're getting in here to see me. You're moving forward. I think that's great. So you reinforce those well behaviors. Uh, we all are subject to this power of suggestion. It may seem a little bit overdone, perhaps the way I've dramatized it, but we're all subject to it, and it works very well with patients. If you're skillful at this is really going to help your medical practice, in my view. So in summary, armed with the proper understanding of the psychology as well as the physiology of pain, you can better help your patients deal with the pain that they encounter in life, which is, as Kath pointed out at the very beginning, so widespread and so commonly encountered in your practice as acupuncturists. You are truly healers. I believe in that, and I know that. And furthermore, you can inspire others to become healers, to follow in your footsteps. And I know and hope that you do that. That's an important aspect of the Hippocratic Oath that asks all of us who are medical healers to inspire others to follow in our footsteps. So I get to show this last slide. This is my son, Tyler. He is now a student at the Boston University School of Medicine. You can see there a proud dad, and you can see a son who is on a healing track of discovery and helping other people. And you can tell he's already outdoing his old man. Thank you very much.
I hope you enjoyed this free webinar. Please take a moment to subscribe to our YouTube channel and please share on social media. The world will be a better place when more people know about the benefits of acupuncture.